Daktari, morning. Any opening remarks? Ama as we like to say,
Uh,
jumping straight in.
no. Karibu sana to another episode. I don't think I have more remarks other than what we are here for. Yeah.
Yeah. So again, today is on genetics, antimicrobials, and resistance. And I think many people have termed it as the next pandemic. And we will be looking at that. I think importantly, we'll be also trying to flesh out where data comes in one way or the other. So hopefully we see how that goes. But I think to start us off, I've just remembered when I was working at the clinic back in Nairobi. One of the many cases I used to face day in day out was treating flu, and patients would come in with a flu or a cold, and they would come and say, daktari, nipatie ile ya siku tatu, ile dawa ya siku tatu. So in this case, I was like, okay, we don't. So in this case, they would probably refer to azithromycin for their flu, and they would attribute giving that antibiotic to help elevate their flu symptoms. So that is an important, or it's an interesting case on how the use of continuous use of antibiotics where they are not needed might lead to that progressive antibiotic resistance. And I think that starts off our conversation today. We are trying to look at this intersection of where patients continuously use antibiotics and maybe how as clinicians, how as the health system, we are trying to address this issue by building those systems that are pandemic resistance to whatever, maybe say antibiotic pandemic that might come in the future or something like that. Yes. I don't know if that's.
Yeah. I think what we could also briefly mention is that I know Marcos has been attributed to a lot of deaths globally. For example, in 2019, the statistics show that we had like 4.9, say roughly 5 million people who died because of AMR, drug-resistant infections. I know in Kenya, for example, in the same year, we had like 8,500 deaths that were attributable to antimicrobial resistance, and 37,000, close to 40,000, were attributed to were associated with AMR. So these are conversations that has been going on. I know there's even a whole national action plan, Kenyan national action plan on AMR, and we all the way from even in terms of reporting, we have a classification of drugs from watch drugs and all that kind of stuff. We'll talk about that classification later. But you can see that efforts are in place to try and combat AMR. And you have used a very good example. When you say about a patient who comes to your clinic and says, no, doctor, prescribe for me that dawa ya sikutatu. Is it a compliance issue? Is it a system issue? What is it? Why will these patients maybe prefer to take the 3-day and not the 7-day antibiotic or 5-day antibiotic? So these are some of the things we are going to talk about and how they drive AMR through influencing behavior of health seeking. Yeah, thank you.
You have mentioned an interesting point, and one in which you've said, is it a systemic issue or a patient issue? And I think it I'd say both. One, because the patient might not be informed, and two, because maybe the system is chasing profits, maybe to say so. And in this case, one would think about the implications, the immediate implications of issuing this 3-day drug, and probably think there's really no much implication. and they will think, okay, this drives cells, so why not issue it all along? But when you look at now the implication in terms of the next pandemic, then you start thinking, oh, what's going to happen? And I think in this case, when you look at it now from the, let me say, microscopic point, that's when now we start to think, okay, what's happening? Because when we dish out these antibiotics without proper prescription, proper backed evidence, maybe from culture or even just doing basic lab tests, we get into this issue of resistance. And I think now for the majority of the patients, they need to be aware that if you take antibiotics that are not, for example, properly prescribed or properly backed with evidence, we get this kind of resistance that is coming up. So the resistance can be either natural or acquired, and this is where I think we're sort of seeing some sort of acquired resistance from the bacteria side, from that continuous dishing of antibiotics. So I know the mechanism can get a bit complex depending on the type of bacteria, the type of antibiotics you give, but that is now the space that this pandemic sort of starts to develop. So when we probably be tracing back where the pandemic started, probably say these are the points where we started saw this thing happen.
Yeah, so you have natural and you have acquired. Maybe you could shed some light on how bacteria acquire resistance.
I think from some bacteria are just, for example, bone resistant. So for example, I know something like TB, the TB bacteria is very, very good in terms of resisting even the body immune system, even resisting the drugs that we give them. But also for importance for the audience is to understand that these bacteria are biological agents or biological organisms. So that means that when they face harsh environment, they sort of adapt mechanisms to try and beat whatever is happening. So those mechanisms are adapted through mutation. So what that means is that bacteria will probably face an antimicrobial, and then they will pick up mechanisms to evade that antimicrobial, and then they pass it down to their, let me say, their offsprings in this case. So that mutation is acquired and then or transferred to the next generation of bacteria.
Now you've said something very interesting about mutation, and there's a mechanism. I'll give you an example. So we have Pseudomonas aeruginosa. Um, it has a very interesting mechanism. Let's look at one. We look at pouring. So there's a OPRD sort of, let me call it that way. A porion that is expressed in the outer cell membrane of these bacteria. The mutation, if a mutation happens, these gene or these protein and the genes that express this protein, the main role of this protein is to play a role in antibiotic uptake. It has a carbapenem binding site, of course. Now, when gene mutations occur, they lead to a downregulation in the expression of this gene, the OPRT gene. Now, that's how you find resistance to imipenem. A very interesting clinical case. A few months ago, maybe half a year, I'm not sure about the time, like, can't remember really well. My memory is hazy. There was a case at the Children's Referral Hospital in the NPU ward. There was a case of highly resistant Pseudomonas aeruginosa, and it led to a spike in mortality rates. It was crazy. You see, like I said, we have classification of antibiotics according to the AWARE classification system, where you have access antibiotics, which are mostly narrow spectrum of activity. They have fewer side effects. lower costs, and they also have a lower resistance potential. Now, from there, we have the watch drugs. These watch drugs or watch antibiotics have a higher resistance potential. And usually, the access drugs, they are usually first or second choice, just the same as watch. But now for watch drugs or watch antibiotics, sorry, they are first or second choice to a very limited number of infective syndromes. And then now you have the reserve. The reserve, we have examples like imipenem, colistin, novel. I don't know if I should call them novel, but they're last resort antibiotics, and they include novel antibiotics or new antibiotics. So in such a case, when you have highly resistant, like you've mentioned something to do with TB. Anyway, when you have highly resistant bacteria, you have these reserve drugs that you are sort of your last option. Now, in this case, in the clinical case that I've just cited, even that was impossible. So it was really unfortunate. A lot of lives were lost. Uh, yeah, I think that's a perfect example of what happens when you have resistance.
So yeah, I think that's an important case when you've mentioned it on the clinical setting, because I remember when we were in ward rounds, what used to happen was that a patient would come in, we would work up their labs, then come up with a diagnosis, and then obviously due to some constraints, we are not able to get, for example, blood culture. Okay, so if you're not able to get blood culture, then we go with the management, maybe protocol management of this condition. So let's say is the patient maybe would require IV ceftriaxone, so they're given. So once maybe they complete their dose, the patient's symptoms haven't remitted. So maybe they came in still high fever. They came in with maybe there's not really localized infection somewhere, or even if they sometimes can be even a wound. Sometimes even there's even presence of localized infection. So after completing that dose, the symptoms are not remitting. Then the question is, okay, can we get that culture? At this point, you are a bit late, but let me say, due to that systemic setting, maybe you find blood culture, and then when the results come back, you just see all this profile of these microbial drugs being resistant to from the sample that you took, and then now you start going down the pecking order of the reserve drugs, and you're saying, okay, this patient, we can't really get the drug that maybe might clear whatever infection they have seeded. So then it becomes a challenge for the system, because if you have patients presenting with these kinds of resistant, even from these clinical cases, then it's I think it's a systemic. It will become it will explode later on to become a whole systemic issue.
Yeah.
Because if the reservoir drugs are depleted in this case, then it spells trouble.
Okay. I think that's uh, that's well said. We have apart from mutation, we have now the core of today's topic, which is gene transfer. Uh-huh.
So I think for gene transfer now, how the we've said the bacteria might have various mechanisms, and I think one of the mechanisms that explains this well is the mechanism around plasmids. So plasmids, in short, they are like, how can I say? The bacteria normally, as you've mentioned, has some genetic makeup. Some of this genetic makeup are within the bacteria, others are sort of outside sort of the bacteria, something like that. So these plasmids are kind of circular, small DNA fragments within the bacteria. Yes, and they are separated from the main chromosome of what this bacteria really has, the main genetic type of this bacteria. And the reason is because these plasmids will be used now for that transfer. So this plasmid, for example, think of, for example, like you have a USB drive, and then I give you the USB drive. So me giving you the USB drive is like that plasmid giving you the USB drive. But in this case, that USB drive is encrypted with how to evade microbials. Okay, so this USB drive in this case will be your antibiotic resistant genes kind of mechanism. So when this is transferred down, it gives the other other bacteria ways or mechanisms now to evade the continuous exposure of the antimicrobial, and normally they can replicate independently. So that means that it doesn't have to depend on the life cycle of this bacteria for it to replicate. So they can move between bacteria. So the plasmids, for example, as I've mentioned, the plasmid within this USB, if I give it to you, it will replicate and so on and so forth. So this means that one resistant bacteria can share resistance with others. So for example, if I've treated you with some certain antibiotic and you've developed resistance, that bacteria can share that profile of resisting that antibiotics with other bacteria.
Mm. All right, all right. I think you you have summed it up well. You have talked about sorry, the transfer of the gene transfer in AMR. We have two. We have what you have described is, I think, horizontal, where we have horizontal gene transfer through conjugation, and we also now we have two types: vertical and horizontal. Of course, vertically is when bacteria replicate or divide, and then laterally is from one bacteria to another. And here, plasmids also play a role. Yeah. So, uh, having said that, I think we have covered how it happens in the wards. One thing I'd like to say is this goes beyond the hospital setting. Our primary our primary healthcare is particularly notorious. We have seen a lot of pseudo experiments of high profile individuals maybe walking to a pharmacy out there, community pharmacy, and ask for antibiotics, and they are sold like what can be. So how do we that is of course another conversation, but I'm just looking at it from a system angle. How do we rein this in? How do we prevent that? You cannot you cannot I usually insist on the why. You cannot enforce something that the citizens or maybe these patients do not know it's good for them. Of course, for them they're after convenience. But you find that if you're after convenience, then it might not necessarily be good for you in the long term. There's no prescription whatsoever. You have a flu, you have not been tested, and you conclude, oh, I do need antibiotics. Worst of all, I do need antibiotics for 3 days, which is maybe azithromycin, one of the most abused antibiotic out there. Then when you come for other conditions that actually require us to maybe give you azithromycin, we find that you are resistant because you treated a flu that's probably viral, which will have dissipated by itself after what 5 7 days by forcefully taking antibiotics. So I think that's it's a it's a it's a very tricky situation where you have unethical dealers or unethical professionals who sell antibiotics without prescriptions, no proper testing done. So you just treat empirically, and whatever you're treating, you have already administered maybe a watch or an or a reserve antibiotic. And we also have the patient side who go demanding, knowing very well, I probably do need a test and a prescription for this. Anyway, yeah. So what do you have any thoughts on that, or should we move on to that?
I think for that, one important thing is to develop trust with the patient. I think one where I used to sit at these clinics, I it used to be a fight, and it's one that I was willing to go down with these patients, especially when it actually came to pediatric patients, because a mother would come in genuinely, they have their sick baby, and they probably having, as you've said, a flu that will clear in 5 7 days, but they would really insist that they want these antibiotics, and it was up to me to stand firm and say, Mom, we can't give this for this. And you'll have to break it down to them what is really happening in this case. And I think developing that trust requires more time between you and the patient. It will be very hard for you to develop more trust if you're only one clinician seeing 200 patients, for example, in a queue. That means you want to move fast, and in this case, you probably won't have the patience of explaining to a mom why it's important, for example, for her not to give her child antibiotics in this case. So it comes down. Okay, when you say the system, it comes also down to that. Are we equipping our clinicians with the right, for example, time, with the right even lab tests for them to be able to reinforce this fight of antimicrobial resistance, and continuous education to the patient. I mean, one thing I never fail to do is we you can't underestimate educating the patients. This is the one key that they probably will go home and they will tell more and more of their colleagues, relatives, and so forth. So I'd really say trust and equipping our clinicians are the most important thing for us even to think about, as we also reinforce other areas. Because one thing I realized when I went to this time we had this Kenya One Health conference, I I wasn't aware that even farmers give antibiotics to chicken without proper prescription, and that can be a source of antimicrobial resistance. And I was like, oh, I really even didn't know about that. So even that for myself is a point of education. So that means even means educating even farmers who use antimicrobials for their poultry and all that kind of stuff. So that means that we address this thing not only from the clinical perspective or from the ward perspective, but bringing all key players, even just from the One Health approach.
All right, all right. So let's look at you have mentioned One Health approach, and that's very. I think we should have a separate episode for that. There's a whole mechanistic explanation of how PMR occurs beyond, of course, the genetic aspect or the social behavioral aspect where you have these patients or our own prescription or prescribing behaviors, how they influence. You can also get it from food, like you said, because maybe the farmers not only uh, livestock, but also crops and stuff like that. Yeah. So how does the Kenyan landscape look like in terms of data?
Ah, that's an interesting one. One I haven't for example, dove deep into. In terms of data, I think one particular case, for example, that comes into my mind is I think I was in internship, and then there was this study that they were doing. They were looking at I believe it was blood culture and sensitivity in amongst Kenyan hospitals. So I think that was the one bit that I've come really into contact with this kind of studies or data. So in this case, what they were doing, they were trying to implement what we call this hub and spoke. Is it hub and spoke method? So where
Urban spoke model, yeah.
yeah, hub and spoke model. So in this case, the idea is we have different satellite hospitals really increasing their capacity in terms of blood culture and sensitivity, so that we can have that, for example, data bank, or how can I say, repository of how to get this profile. So that was basically the idea. uh, I I think it was more of a pilot study I'm not aware of how this data has been used or maybe has been integrated within the system, but it was sort of a type of a clinical trial kind of thing, this thing. So the idea here was clinicians most of the time rely on, as I've said, clinical judgment or lab testing, and the cost of this test is normally high. So the idea is, okay, how can they happen within these hospitals, and then maybe that now being taken up the spoke method now to the hubs, no, to the, how is it called? What's the central point of this scale? Because those are the hubs. And
That's
up,
the hub.
oh,
That's the hub.
okay, yeah. So how they can taken up to the national, for example, repository, and be shared. I think that was the whole idea of this study. So something I think is important there is when you have this kind of studies where we are trying to implement regional places where you can be able to collect these samples, you can be able to collect this culture. We realize that there's sort of some limitations in terms of lab capacity. Are there even personnel who can actually continuously collect these samples for you to have that regional what can I say, information in this case? Because I'm thinking we were at Kirinyaga County. So I'm thinking, okay, in this county, do we have that capacity for us to implement that continuous lab testing? And you look at another county, do we have that capacity? So you find that the limitation here is that some counties might have the capacity. Some county hospitals might have that capacity of continuous testing, continuous picking up of samples, and taking it back to the main repository. And then for other counties, the capacity might not be there, and it goes down to the systemic issue. How do you make sure that this thing happens across all hubs or across most of the other counties?
So yeah, you've raised a good point on data infrastructure. How do we ensure uniformity of data? How do we ensure that we move from manual methods to maybe digital methods, which are more robust, which are more let me settle with robust, yeah, and they are even easier to audit. They are easier to follow through, because you'll find most of our public hospitals, even with the with the program, maybe to I know there's a program. There's a program at the county level and at the national level. Of course, it's a sort of a PPP program, private public partnership. With, I'm forgetting one of the private partners. But yeah, there's the NASIC program and the CASIC program, the national. What? Let me look that up real quick. Where you have these committees that are set up to facilitate the surveillance of antimicrobials or AMR at the county level and at the national level. That is one big step, I'd say. But are there systems in place? In as much as you are teaching maybe clinicians, doctors, pharmacists, all these guys, how to combat AMR, do we have the infrastructure in place? And if not, then how do we proceed from there? Yeah, we could say we have recommendations such as better surveillance, better antibiotic guidelines. The guidelines are there. The guidelines are there. Smarter prescribing practices. But how about on the on the on the private side, in terms of at the community level? We are focusing on the hospital level. How can we bring in patients as well, in terms of educating them and making them not only observers but active participants against the fight of microbial resistance? Yeah. So
I think that's an interesting bit. But now even you take it down further even to the patients at this community level, because when you talk about surveillance of antimicrobial resistance, what gives you that element of surveillance is if you can be able to test. So in this case, now if I can remember well, is from that hub and spoke method. They were probably looking at they're focusing at specific pathogens. So that means that when their eyes are on some specific pathogens, they're focusing on that. That is what we call now surveillance. So how this happens, or how it goes down to the community systems, just beyond just hospitals, then you can look at how can I say, you can even look at beyond hospitals and look at dispensaries, how they can play a role in this. I'm thinking of community health workers, how they have been involved in all this. I'm really not seeing it at the moment, but that would be an interesting point, maybe, to see how they can involve if it is possible. But I think also, again, we still come back to the infrastructure, even the cold chains of things, how to move these samples. Uh, yeah, I think also the importance of this hub and spoke method is that because you can able to address the supply chain bit of it, because instead of taking this sample all the way up to the main hub, these regional hubs can address that testing there and then. The cost can be the cost will be obviously much lower to do this testing, but I think the government must bear the burden of the initial cost of setting these things up for it to work. And that's how surveillance works in this case. If you are able to bring surveillance down to these community units, down to these regional units, then to some extent it might work for this population. One one bit of evidence I came across was now from our neighboring country, majirani Tanzania. I think jirani wali roll out a program in which now they were giving the lab technicians some training in terms of doing data surveillance. So in this case, you are using the health workforce as an important key, or an important piece of this puzzle of solving for surveillance. So you find that the lab technicians are equipped with some data processing or data knowledge in how to maybe process, maybe pick up these things. So at the end of the day, you've got the workforce even given the power to assist with this surveillance. That means that when the next pandemic happens that arises from antibiotics, we can be able to spot it and say this is where it arose. If there is, for example, quarantine needed, we can do quarantine in this and this manner. Otherwise, if it just arises, then it becomes helter-skelter and panic everywhere before we actually find the proper solution of how to contain this.
Very interestingly, there's a national action plan for MR. I don't know if you knew that. And that's what I was referring to when I was talking about CASIC and NASIC. So there's the NASIC, of course, it's the National Antimicrobial Stewardship Interagency Committee. It's composed of different players and professionals. Now, at the county level, of course, same goes. We have the CASIC now, the County Antimicrobial Stewardship Interagency Committee, and they are tasked with, among others, implementing the National Action Plan for the AMR. It runs from 2023 all the way to 2027. There's a Daktari Ombajo, Dr. Luis Ombajo, very, very brilliant doctor. I think she was on NTV a couple of months ago. She also touched on AMR. I think she's the outstanding champion when it comes to AMR in Kenya so far, whatever, the way I know. We had a training with her also some time back during the launch of the classic committee in my county. Yeah. So let's summarize all the points that we've talked about. I think it's a multifaceted approach towards AMR. It's not just pana wacha kutumia hiyo dawa vibaya and tumia dawa vizuri kind of approach. It has a lot of things to consider, or rather approaches to consider.
Yeah, and that's actually it's one of those conversations that are not like, we can't limit it to just one sitting and say, okay, we are done with the MR. There's obviously, again, dozen different players. For example, from you just mentioned, if we even talk about the One Health approach, we can see different players, how they can contribute into assisting with this AMR issue. I think now, in terms of summary, from where I sit, I'll obviously be biased and see and approach it as a point of an MO, which I think one of the one of the one of the best things I realized being an MO is the power really to educate your patient, because patients normally have that trust in you, and you sit in that system where you can really push for evidence-based medicine, even though your patient might not understand why, but you can put it in a language in which they will understand why. And sometimes you have that pressure of making sales, for example, something like that, from a system. But I think protecting the patient surpasses any other incentive out there. So I think for me, that's where I normally start. Have I educated the patient enough for them to know you can use this antibiotic, or why are you using this antibiotic in the first place? Then from there, I see it as a point number one from the patient side, to make sure they complete the end of the bargain. So the patient also in this case has a responsibility to see this through. Otherwise, if they don't see this through, then sort of add more fuel to the fire. Then on the other side of things, now we look at this at a systemic point of view. From the systemic point of view, down to the labs being reinforced with the correct, for example, equipment, the correct testing mechanism, the correct even data infrastructure. We've been talking about health information system and all kind of stuff. Then the question is, how can we even reinforce the testing that happens in the labs? Those are also important data points. That's like in terms of the systemic interplay. From the point of science, the idea, we haven't even touched about this, is that in as much as we do the testing and we do all that, there is that point of research on trying to look at, okay, biologically, how are these, what is the information that we're getting from this resistance chain of, for example, some certain bacteria and all that kind of stuff. I think having a database that can show us that interplay, even as a country, would be important. That will help us also know how to even develop maybe drug development, those kind of stuff. Maybe we are far away from that by now, but those again are important areas that we could look into. Yes, that could help us address the AMR thing as a larger population. So even that will require more reinforcement in terms of labs within that area, regional.
Because I know genomic technologies have really come through for monitoring, mobilization. You want to monitor the mobilization, persistence, the abundance of these genes and mutations within microbial populations, and of course human populations. You'll be able to do better stressing of the MR pathogens, and without forgetting modeling. Yeah, these technologies can really help you to model the evolution of AMR and transmission. Okay, because I'll give you an example. You have a case where maybe we have an outbreak of a particular pathogen or disease in some certain region. Then you find that over the years, even if you look at the consumption, maybe from the last 2 decades, they have been consuming hey, we can use even KEMSA, for example, right? Look at their data and where the supplies of these watch drugs or reserve drugs are going to most. Which region is it? A, B, C, or D? Then from there you can be able to say if this continues, let's model what we are likely to expect from this particular region. But like you said, we are not yet there, and it will be a delight for us to push ourselves to get there as soon as possible, and yeah, maybe be able to contain this crisis. I'd call it a crisis because you already saw the numbers when we started this episode. Yearly, it's like 1 million deaths plus. So all avoidable, all avoidable.
I think also it sets the stage for future episodes in terms of just looking at experts who have maybe explored this in depth. I would really like to see the genetic profile on how we collect this kind of data if it exists nationally, because from the national approach it's more of the systemic, the infrastructure, the even not much on the social behaviors. You've actually alluded it to quite a lot, but that kind of data is what exists nationally. I am sure there is some data bank somewhere that to some extent has captured the genetic scope perhaps of this bacteria and the antimicrobial resistance profile. And just to sum it up, also would be really interested to look at it from the One Health approach, because this is now where the modeling comes into full. Like you can see, you can appreciate it how it happens, and that will be one place.
And Dr. Just before we conclude, you've mentioned something very interesting. You've mentioned about if we have a genomic bank, then it will be interesting to see and understand the genetic interactions of our own population, right? We'd be able to, you see, because some of these things, they're determined genetically. I cannot give you the same dose as maybe your neighbor who has another variant of the same gene, which probably affects metabolism, probably affects, the whole pharmacodynamic interaction of this drug in your body. So with that said, is this the reason why we could also see some being resistant to some antibiotics or not? There's surely no way for us to find that out if we do not have a genomic bank, which will also lead us to another conversation of personalized medicine. Right?
Yeah,
And yeah, personalized and precision medicine. So it is really fascinating that from everything starts, not does not end, but starts at least from a genetic look or outlook. From there, you can be able to look at the bigger picture and be, oh, I think here are the insights that will really help us cap these. Yeah.
okay, thank you, Doc. So, I'd like to close it there. To our audience, thank you very much. We've covered a lot in this topic. We've been all over looking at how the next pandemic might arise in the scope of antimicrobials. And in this case, we've covered the clinical picture, how we normally see it unfold, all the way to the systemic bit of things, how they might unfold in that perspective, ways in which you can try to reinforce. I mean, every player within this game of antimicrobial resistance has a role to play, be it the clinician, be it the doctor, be it anyone in charge of the systems. We haven't talked about politicians, but even them, they have a role in one way or the other. So until next time when we meet again, it's been your host David and I na daktari kutoka pwani, si Kenya.
Dr. Clinton operated. Thank you so much.
Sawa sawa.